Acid-base balance refers to the homeostasis of the hydrogen ion concentration in body fluids. The way that it is measured is called the pH scale. Body fluids are further classified as acids or bases according to their hydrogen ion concentration. As the hydrogen ion concentration increases, the pH level goes down, indicating that the person is in acidosis. As the hydrogen ion concentration decreases, the pH level increases, indicating that the person is in alkalosis. The normal arterial blood pH range is 7.35 to 7.45. A pH level below 6.8 or above 7.8 is considered incompatible with life. Because cell function becomes seriously impaired, those numbers would result in death. Acids are known as hydrogen ion donors. An acidic solution has more hydrogen ions and a pH of less than 7.35. The excess of hydrogen ions can be a result of overproduction of acids that causes the release of hydrogen ions and an under-elimination of acids that causes retention of hydrogen ions. Because hydrogen ions are positively charged, hydrogen ion excess in the blood causes imbalances in other electrolytes such as calcium, potassium, and sodium. These imbalances can lead to disorders of the cardiac, central nervous, neuromuscular, and respiratory systems. Bases are known as hydrogen ion acceptors. A base or alkaline solution has fewer hydrogen ions and a pH of greater than 7.45. Alkalosis can result from either an overproduction of base or an under-elimination of base. The most common base is bicarbonate, and the systems affected are the cardiovascular, muscular, and nervous systems. Oxygenation is measured using arterial blood gas sampling. The PaO2 measures the partial pressure of oxygen in arterial blood and is the most important factor in determining how oxygen binds to hemoglobin. If the PaO2 is high, the more oxygen is able to bind with hemoglobin. If the PaO2 is low, then less oxygen is able to bind with hemoglobin. The SaO2 measures the oxygen carrying capacity of hemoglobin and can be assessed through the use of pulse oximetry. Primarily, SaO2 is used to evaluate respiratory function and is not used to evaluate acid-base balance. Higher than normal PaO2 and SaO2 values are associated with unnecessarily high levels of supplemental oxygen administration. In contrast, lower than normal PaO2 and SaO2 values indicate hypoxemia. A normal PaO2 range is 80 to 100 milligrams of mercury, and SaO2 normal range is greater than 95%. There are exceptions to the rule if the person has other disease processes such as COPD. But what you need to know is PaO2 is 80 to 100. If it's less than that, then we're going to have to supplement with oxygen. Carbon dioxide is a natural byproduct of cellular metabolism and is measured by the PaCO2 levels, which indicate the partial pressure of carbon dioxide in the arterial blood. The PaCO2 is used to evaluate the respiratory component of acid-base balance. Primarily regulated by the ventilatory function of the lungs, normal arterial carbon dioxide levels are 35 to 45 millimeters of mercury. So if the PaCO2 is greater than 45 millimeters of mercury, it's related to hypoventilation or excessive CO2 retention. Therefore, the patient is in acidosis. If the PaCO2 is less than 35 millimeters of mercury, it is related to hyperventilation or excessive CO2 exhalation, and therefore the person is in alkalosis. Bicarbonate helps the body regulate pH and accomplishes this by its ability to accept a hydrogen ion. Regulated by the kidneys, bicarbonate is measured by the arterial blood HCO3 concentration and is used to evaluate the metabolic component of acid-base balance. The textbook does have one value, but the lab values that we have as a program is 24 to 28 milliequivalents per liter. So if the bicarb is less than 24 milliequivalents per liter, then the person is in acidosis. If the bicarb is greater than 28 milliequivalents per liter, then the person is in alkalosis. So those are the values that we're going to use. The first line of defense against a change in the body's pH is chemical buffers. Chemical buffers include bicarbonate, phosphate, and proteins. Bicarbonate buffers are mainly responsible for buffering blood and interstitial fluid. They rely on a series of chemical reactions in which pairs of weak acids and bases combine with stronger acids and bases to weaken them. These chemical reactions are assisted by the kidneys and the lungs. Phosphate buffers are found in the intercellular fluid as bicarbonates. They control small fluctuations in pH and respond quickly. They prove especially effective in the renal tubules where phosphates exist in greater concentration. Protein buffers are the most abundant buffers in the body. They work both inside and outside of cells. Hemoglobin inside the cell and albumin and globulins outside the cell. Protein buffers work by binding with acids and bases to neutralize them. First off, don't let this slide scare you. We're not going to be doing any type of chemistry type equations, okay? Acid-base disturbances resulting from primary alterations in the PaCO2 are regulated by respiratory buffers. Any retention of CO2 or increase in the body's concentration of CO2 produces an increase in hydrogen ions through the generation of carbonic acid, which is H2CO3. This lowers the pH and thus promotes the development of an acidotic state, which is observed in conditions such as chronic obstructive pulmonary disease. While in the acidotic state, chemoreceptors in the brain respond to the increased CO2 levels by stimulating the respiratory system to increase the respiratory rate and depth in an effort to excrete CO2 through the lungs. Conversely, decreases in CO2 concentration result in a decrease in hydrogen ions. This leads to a pH rise and an alkalotic state results, as seen in conditions such as hyperventilation. The renal buffers are the most effective, yet the slowest acting buffering system, and buffer by regulating bicarbonate levels. If the body is in a state of alkalosis, then the kidney excretes bicarb and reabsorbs hydrogen ions. This results in urine becoming more alkaline, a drop in the blood bicarbonate levels, and a decrease in pH. If the body is in a state of acidosis, then the kidneys excrete hydrogen ions and reabsorb bicarb. This results in the urine becoming more acidic, bicarbonate levels increasing, and the pH increasing. This response to acid-base imbalances begins within hours but requires several days to be marginally effective. This is in comparison to the faster changes brought about through the increases or decreases in the respiratory rate. Normal pH results when the balance between carbonic acid H2CO3 and bicarbonate HCO3 is maintained. In all cases, a pH level below 6.8 or above 7.8 is considered incompatible with life, and death will likely ensue. Compensation describes physiological responses to an acid-base imbalance in an attempt to normalize pH. If the problem is of respiratory origin, then the kidneys work to correct. If the problem is of renal origin, then the lungs work to correct. If the primary alteration in acid-base balance has resulted from a metabolic disorder, then the respiratory system may compensate by retaining or removing CO2 while minimizing a change in the pH. The lungs may take as little as 5 to 15 minutes to begin compensation. The respiratory system responds to metabolic-based pH imbalances. So for metabolic acidosis, you'll see an increase in respiratory rate and depth. For metabolic alkalosis, you'll see a decrease in respiratory rate and depth. If the primary alteration in acid-base balance results from a respiratory disorder, then the renal system may compensate by excreting or retaining hydrogen and bicarbonate. The renal system may take as long as 24 hours to correct a respiratory-induced problem because there are three major renal mechanisms that work to compensate the disorder: tubular kidney movement of bicarbonate, kidney tubule formation of acids, and the formation of ammonium from amino acid catabolism. So in respiratory acidosis, increase in hydrogen excretion and bicarbonate reabsorption occurs. For respiratory alkalosis, there's a decrease in hydrogen excretion and bicarbonate reabsorption. Okay, now we're going to determine acid-base compensation. Okay, so first we need to look at pH. Is the range within normal limits, or does it indicate acidosis or alkalosis? Step 2, has the PaCO2 or HCO3 changed to account for the acidosis or alkalosis? So we need to see out of those two what matches or which one matches the pH. That's going to tell us if it's a respiratory problem or a metabolic problem. Then step 3, has the opposite system worked to correct and shift back toward a normal pH? So that remaining parameter, did it move out of range to fix the main problem, or is it within range? Arterial blood gases are further defined by their degree of compensation. So an ABG can be uncompensated, partially compensated, or fully compensated. Uncompensated, the pH is abnormal, and either the PaCO2 or the HCO3 is also abnormal. There is no indication that the opposite system has tried to correct the imbalance. That's why it's considered uncompensated. Partially compensated, the pH is abnormal, and both PaCO2 and HCO3 are also abnormal. This indicates that the opposite system has attempted to correct for the other one, but has not been completely successful. Then fully compensated is the pH is normal, and both the PaCO2 and HCO3 are abnormal. The normal pH indicates that one system has been able to compensate for the other. Okay, so we've been talking about arterial blood gases, but who is the person that actually obtains them? I've always seen the respiratory therapist. I've not seen the registered nurse. However, we'll always need to follow institutional policies. Most ABG samples are collected by the respiratory therapist or a specially trained nurse. Collection from the femoral artery, however, is usually performed only by a physician or an advanced practice registered nurse. I can tell you as an APRN that I have not been trained to get an ABG. Before a radial puncture is performed, an Allen test should be conducted. This test is conducted to ensure adequate collateral circulation in the event there is hemorrhage or thrombosis of the radial artery that is punctured. Okay, so we got to check the pH. Is it between 7.35 and 7.45 or something different? For PaCO2, remember our range is going to be 35 to 45 millimeters of mercury. And then for bicarb, we're not using the textbook. We're using 24 to 28 milliequivalents per liter. Read over this slide, but don't get freaked out. We're going to work out some problems together at the end of this lecture, and then in class we're going to do some more, okay? Respiratory acidosis is the primary acid-base imbalance resulting from altered ventilation leading to CO2 retention. Characterized by a low pH and elevated CO2 levels due to alveolar hypoventilation, respiratory acidosis may be acute or chronic, as in the case of COPD. The body attempts to compensate by renal absorption of bicarbonate. So we need to treat the reason why the person is in respiratory acidosis. When the underlying cause is respiratory, the correction or improvement in ventilation is to lower the PaCO2. When the underlying cause is non-respiratory, then correction or improvement of the underlying cause must occur. Before a nursing diagnosis or intervention can occur, the nurse must obtain a comprehensive patient history, identify health problems associated with respiratory acidosis, check for clinical manifestations of respiratory acidosis, obtain vital signs for a baseline comparison with future vital signs, and assess ABG values, particularly the pH and the PaCO2. Nursing interventions for patients with respiratory acidosis include maintaining the patient's airway, monitoring ABG levels, monitoring vital signs, especially respiratory rate and depth, administration of supplemental oxygen, assisting with intubation if necessary, monitoring potassium levels, administration of sedatives cautiously, and providing patient reassurance and teaching as needed. Respiratory acidosis results from altered ventilation leading to CO2 retention. In response to prolonged increased CO2 levels, paralysis and coma may result from cerebral vasodilation. Respiratory alkalosis is an acid-base imbalance caused by an increase in the rate of alveolar ventilation. Acute alveolar hyperventilation is frequently the result of anxiety and is commonly referred to as hyperventilation syndrome. Hyperventilation decreases serum CO2 in the lungs and blood because CO2 is eliminated by the increased rate of respirations. A decreased CO2 concentration decreases the levels of carbonic acid and hydrogen ions circulating in the blood, therefore raising the arterial pH levels. The body tries to restore the pH to normal levels through renal compensation. In this process, renal excretion of bicarbonate is increased. Respiratory alkalosis may be acute, resulting from hyperventilation, or chronic, which can be difficult to identify because of the renal compensation. To treat this, we always want to figure out what the cause is and correct that. Reduce fever, eliminate the source of sepsis, oxygen therapy, a sedative or anoxylytic therapy, and diuretics is needed. Key nursing interventions for patients with respiratory alkalosis include assisting in achieving the goal of reducing the ventilation rate by encouraging slow, deep breathing, monitoring vital signs, providing emotional support and reassurance to the patient to reduce anxiety, assisting the patient with activities of daily living, and providing teaching as needed. Respiratory alkalosis results from an increase in the rate of alveolar ventilation. Hyperventilation decreases serum CO2 in the lungs and blood as CO2 is eliminated by the excess respirations. Complications of respiratory alkalosis include seizures related to decreased oxygen carrying capacity to cerebral cells, and chest pain from cardiac and non-cardiac causes related to anxiety and hyperventilation. Metabolic acidosis is an acid-base imbalance caused by an increased accumulation of metabolic acids that rise in proportion to a decrease in bicarbonate and result in decreased arterial pH. Metabolic acidosis treatment depends on the underlying cause. Sodium bicarbonate replacement administered IV neutralizes blood acidity in patients with a pH lower than 7.1. As needed to maintain fluid balance, parenteral fluid replacement may be used. Rapid-acting insulin may be needed for patients with diabetes in order to reverse diabetic ketoacidosis and drive potassium back into the cells. Antidiarrheals may be used to treat diarrhea induced by carbonate loss. Dialysis may be needed for patients with renal failure or for metabolic acidosis caused by a toxic reaction to medication. Lastly, mechanical ventilation may be initiated to assist respiratory compensation. Before a nursing diagnosis or intervention can occur, the nurse has to get the patient history of clinical problems and identify health problems associated with metabolic acidosis, such as starvation, severe or chronic diarrhea, diabetic ketoacidosis, trauma and shock, and renal failure. Interventions include assessing the arterial bicarbonate, base excess, and serum CO2 levels for metabolic acid base imbalances, obtaining baseline vital signs for comparison with future vital signs, and checking laboratory results, especially blood glucose and serum electrolytes. Key nursing interventions for patients with metabolic acidosis are specific to the underlying cause and include monitoring hemodynamic status through blood pressure, pulse rate, respirations, and cardiac rhythm, and assessing peripheral vascular status. Cautious administration of sodium bicarbonate may be indicated, along with providing patient reassurance and teaching as needed. Metabolic acidosis results from an increased accumulation of metabolic acids that rise in proportion to bicarbonate and leads to a decreased arterial pH. If the pH falls below 7.0, cardiac dysrhythmia can occur. This happens as a result of changes in cardiac conduction, which occur in direct response to a decrease in pH and because of the effects of increased hydrogen ion concentration on plasma and intracellular potassium levels. If metabolic acidosis is caused by chronic renal failure, complications may include renal osteodystrophy and renal encephalopathy. Metabolic alkalosis is an acid-base imbalance caused by an increased loss of acid. Most instances of this increased loss of acid are through the GI tract, usually via vomiting or nasogastric suctioning or through renal excretion. The loss in metabolic acid causes an increase in the arterial pH level, which in turn results in a reduction in the hydrogen ion concentration. The body's attempt to compensate occurs by creating a state of hypoventilation, which works to conserve PaCO2 levels. Additionally, in order to increase serum hydrogen ion levels, serum potassium is pumped into the cell in exchange for the serum hydrogen ions. This decreases the serum potassium levels while the intracellular potassium levels increase, resulting in hypokalemia. Metabolic alkalosis treatment depends on the underlying cause. Discontinuation of potassium-wasting diuretics and nasogastric suctioning may be necessary. Patients may be administered an antiemetic to treat underlying nausea and vomiting. Lastly, in order to increase renal excretion of bicarbonate, medications may be administered if the patient is not volume compromised or hypokalemic. Key nursing interventions for patients with metabolic alkalosis are specific to the underlying cause, but include monitoring hemodynamic status through respirations, pulse rate, and cardiac rhythm, and assessing the patient's level of consciousness. Additional interventions include administering IV fluid and electrolyte supplements as prescribed, and providing patient reassurance and teaching as needed. Metabolic alkalosis results from an increased loss of acid. The loss in metabolic acid causes an increase in the arterial pH level, which in turn results in a reduction of the hydrogen ion concentration. With a pH greater than 7.55, dysrhythmias and a coma may result from alterations in the depolarization of neuronal and cardiac muscle cells. Okay, for this first one, I put your normal range is to the side of it, okay, just in case you don't remember. But let's look at the pH. 7.26. Is this lower than the normal range? I'm going to say yes. And then since it's on the lower end of the pH scale, this means that the pH is acid. Okay, so it's acidotic pH. So I would write that to the side of it. Okay, so acid next to 7.26. For the PaCO2, our normal range is 35 to 45. So is that within normal limits? I would say yes. So we're going to put an N next to that one for normal. And then bicarb should be between 24 and 28. Well, this is not that. Okay, this is lower. One thing to mention for bicarb, if the number's lower, it's acidotic, but back up to CO2, if the number is lower, it's alkalotic. It's a alkalosis. Okay, that one's an inverse relationship. So if we have a lower bicarb, going back to that one, we would say that it's acid. Well, which two match? The pH is an acid and the bicarb is an acid. Okay, so both of those match. We're going to call this a metabolic problem because bicarb is the one that's affected. So it's metabolic acidosis. And since the pH, I'm sorry, not the pH, since the PaCO2 is normal, it wasn't affected, it's not compensating. So this would be uncompensated metabolic acidosis. Okay, so let's take a look at this one. This pH is higher. So this one at 7.49, we're going to call it alkalosis. Then our PaCO2, remember last slide I was telling you, this one has an inverse relationship. So if the number is lower than the normal range, it's going to be alkalosis. So next to pH, put alkalosis, and next to PaCO2, write in alkalosis. And then for bicarb, that one's lower, but it follows the same rule for the pH scale. So this one's going to be an acid. Which two match? It's going to be pH and PaCO2. So this is a respiratory issue, and it's a respiratory alkalosis. And then look at the bicarb. This one is close to the normal limit. It's not all the way, but it's trending towards that way. So since it's not yet in the normal range, but it's headed in that direction, we're going to consider this one to be partially compensated. Okay, looking at this one, our pH, it's less than the normal value, so we're going to write next to that one acid. Then look at the PaCO2, it's 52, so it's above the normal range, so we're going to consider it to be an acid because this one's backwards, or I should say inverse. And then bicarb is 34, so this one is elevated, so this time it's going to be considered an alkalosis. Which two match? It's going to be our pH and our PaCO2, so we know it's a respiratory issue and it's respiratory acidosis. But then to explain the compensation part of it a little bit better, look back, slide 19 tells you the steps. It says number 5, does either the PaCO2 or bicarb go in the opposite direction of the pH? And the bicarb is in the opposite direction because our pH is an acid. Our bicarb is alkalosis, it's alkalotic. You can say that term also. So this time it's partially compensated. Okay, this one's a little bit different. Look at your pH. It's 7.36. That's in the normal range, okay? So next to that, you're going to put an N for normal. Now, looking at the normal range, 7.35 to 7.45, which end of it does it sit at? It sits at the acidic end. So in parentheses, put acid, okay? Then your PaCO2 is at 50. It's a higher number. Remember, it's an inverse relationship, so that's going to be considered an acid. And then bicarb is higher than 28, so it's an alkalosis. Which two match? It's going to be the pH and the PaCO2. So this is going to be a respiratory acidosis. This time it's going to be considered fully compensated because the pH was brought back to normal range. Okay, this one, 7.43, is our pH. It is in the normal limit, but looking at the scale, it's on the more alkalotic end of the scale. So we're going to put normal, but in parentheses, put alkalosis. Then for our PaCO2, it's 49. That is elevated. So that is going to be an acid. And then bicarb is elevated also. So it's going to be alkalotic or alkalosis. Out of these three parameters, which two match? It's going to be our pH and our bicarb. So that tells us it's a metabolic issue. And this one is metabolic alkalosis. And since our pH is within normal limits, it's going to be considered fully compensated. Okay, so this one is an acid, 7.28. It's below the normal limit on the acidotic side. So write acid next to the pH. For PaCO2, it's 28, so it's a lower number than normal. So it's alkalotic or alkalosis. Write that next to this one. Bicarb is 18, which is acid or acidotic. And then they listed the PaO2 level on here as 70. Normal is 80 to 100. So 70 is low. We would want to do something about that, right? When you're trying to think about your interventions, don't forget about that. The two that match are going to be pH and bicarb. So that tells me it's a metabolic acidosis. And all three are abnormal. So it's going to be partially compensated. Okay. Look at where the PaCO2 and the bicarb, which one goes in the opposite direction of the pH. And we would say the one that's going in the opposite direction would be the alkalosis, which would be the PaCO2. Okay, so it's partially compensated. Okay, this one, our pH is 7.58. So this would be an alkalotic pH. So write alkalosis next to it. PaCO2 is 35. It is barely in the normal range, but it is there. So we would write N next to it. And then bicarb is 50. So this one would be alkalotic as well, right? Alkalosis next to it. And then our PaO2 is 75. So it's not quite where it needs to be. The two that match are the pH and the bicarb. So this is a metabolic alkalosis, and then this one is uncompensated. Okay, this is the last one for this lecture. We have some practice ones that we'll do next week, so don't worry. pH 7.6, where's that at? It's an alkalotic number, so write alkalosis next to it. PaCO2 is 30, so that is also alkalosis. Write that next to it. And then bicarb is going to be acidic, so write acid next to that. Which two match is going to be the pH and the PaCO2. So this is a respiratory alkalosis. All right, this little chart would be easier if I had done a video recording, but we'll get through it. So for the row of respiratory acidosis under kidney, put increased bicarb. So put an arrow up, HCO3. And for lung, put an X. You can also put retained CO2 in parentheses. For respiratory alkalosis, that row under kidney, put a down arrow and HCO3. So decrease bicarb. Put an X under lung. And then parentheses, put losing CO2. For metabolic acidosis, put an X under kidney and an up arrow under lung with respiratory rate. So put RR, up arrow RR. And then metabolic alkalosis, put an X under kidney and put a down arrow RR for respiratory rate.